Great. So thank you for joining us. It's our 10th talk in the South Asian Women in Higher Education Network's research series for 2026. And for those of you who are new, to let you know, we've been doing these sessions since January 2026, and it's been led by Dr. Rumi Begum, one of our inner circle leads. My name's Dr. Binish Khatun. I'm today going to be leading along with my co-chair Sangeeta. I'm a qualitative methodologist at the Faculty of Biology, Medicine and Health based at the University of Manchester. Like I said, I might have met a few some people here today at our amazing launch event last week. I'm also the Pakistan lead for the network, and today I'll be co-chairing the session with my colleague Sangeeta Pokhrel. Hopefully by now you know that our intention for these sessions is not only to share some of the amazing research our South Asian sisters are doing in the field, but also to give us the opportunity to hear the researchers' story and how they got to where they are. So we encourage new connections and who knows, future collaborations, maybe. I'll now pass over to Sangeeta, who will introduce our 10th guest.
Thank you, Benes. Good morning, everyone. My name is Sangeeta Pokhrel. I'm a lecturer at Computer Science and Data Science Department in Yorkshire University London campus, and I am also the Nepal lead for SAWHE. I'm happy and excited to be co-chairing with this session with Benesh. First of all, I would like to welcome everyone, our speaker, our attendees who are here to listen our the talk from Rizwana Adia. Talking about Rizwana, who is our speaker for this session. She's from University of Greater Manchester, and talking about her profile, Rizwana is a senior lecturer and program lead at University of Greater Manchester and also a professional doctorate student. She brings extensive experience from both academia and clinical practice, and also a proud Queen's nurse. Rizwana has spent many years working within district nursing services as a caseload holder, specializing in providing end-of-life care. Also, her academic and clinical interests center on palliative and end of life care, particularly the emotional and professional impact on those delivering this support. Rizwana's research also focuses on compassion fatigue and its effect on clinicians working in demanding, emotionally complex environment. And without any further ado, I would like to pass this stage to Rizwana. We'll be taking all the questions at the end of her presentation, and we will be there for monitoring this session. Over to you, Rizwana.
Thank you. Hi, I'm Rizwana. Thank you for the lovely introduction, Sangeeta. Hope this work, yeah. So my journey into research. So I'm a district nurse by background. I've spent years providing care in the community as a nurse, especially end-of-life care. That's where I was passionate about and spent most of my nursing career within and providing care. I, since 2019, come into the world of academia as a senior lecturer. I'm program lead within nursing. At the moment, I lead the Masters in Nursing, pre-reg and post-registration. Through my clinical practice, I've supported hundreds of patients at end of life, witnessing the emotional demands it places on nurses. And if you're a nurse or any healthcare profession by your background, you'll remember certain patients for the rest of your life. These experience highlights the often unspoken impact of sustainable emotional labour, including signs of compassion fatigue in myself, which reflecting now and since I've been doing this research since 2022, I feel that I also suffered from compassion fatigue, and it was one of the reasons why I feel I left clinical practice and came into the world of academia. So compassion fatigue. What is compassion fatigue? That was the first area that I wanted to look at. What is it and how is it defined? Compassion fatigue is challenging to describe, and it was first identified as a unique form of burnout that caregiving professionals were facing, and it was cause of concern within A&E nursing in 1992. Figley then elaborated on this definition further, and it he says it manifests due to repeated exposure to another person's trauma, and that it was very different to burnout. The difference in compassion fatigue, it occurs when the helper or the nurse is unable to help or rescue the victim, the patient, from suffering that they're enduring. This causes intense guilt and sorrow for the professionals, leading to emotional distress. Whereas burnout is caused when an individual is unable to complete their goals, causing emotional exhaustion. However, it's still defined as a form of burnout due to how it presents itself. Since its initial identification as a cause of concern within nursing, it has been researched within specialist areas such as oncology, ICU, palliative care, and hospice and dementia care nursing. And the agreement is that these nurses who work in these areas are increasingly likely to suffer from this fatigue due to the nature of their specialism, as they are increasingly likely to be exposed to suffering, deterioration, and death of their patient. Community nurses care for these patients within all of these speciality areas, but the care they provide is within the patient's home. Compassion fatigue rates have been exacerbated by the pandemic due to the number of patients that were being seen, adding to this increasing exposure of suffering and death that was witnessed by the profession. Post-pandemic, the pressures on the profession remains due to the recovery from the pandemic, financial constraints on the health service, poor staffing level, and increasing level of sickness among staff. The community nurses service is not sheltered from these impacts. However, the service is further impacted by the changes within the NHS service provision and the vision of care being provided closer to the patient's home. This meaning the service is seeing more and more acutely unwell patients that they would traditionally have been seen in the acute setting. Adding to this, there's a decline in the workforce, as a recent CQC report has highlighted. Compassion fatigue leads to forgetfulness, exhaustion, increased level of stress and anxiety, negative attitude to day-to-day tasks, poor judgment, reduction in attention span, physical illness, reduced or broken sleep. All of this impacts the ability to provide care. Research has been completed on compassion fatigue, and nursing has explored contributing factors as well as supporting factors. These include the age, gender, experience, marital status, and how this impacts or supports the professional manage compassion fatigue. The impact of spiritual care on professional well-being has been researched, but it's researched separately as well, and its outcome on mental health. There has been a positive link. UK research has explored the impact of compassionate leadership and why it's important to support the mental health and well-being of staff post-pandemic. However, due to the current restraint on the NHS, I wanted to explore how these things come outside of how we can support staff outside of the support network or other training platforms or further training to give professionals to look at how individuals can support and manage their own compassion fatigue, as well as to include my passionate area of community nursing staff, which we're highly ignored and not included in research. So that was the reason why I included community nurses. So my gap in inquiry was community nurses' experience of compassion fatigue when caring for end-of-life care patients and their ability to identify it, manage it themselves. So my aim and my objectives were clear. I wanted to know if our community nursing staff are able to recognise compassion fatigue when caring for dying patients, and to explore the strategies they use to manage this fatigue and to identify factors that influence the management of this fatigue, and wanted to look at lived experience from the community nursing staff's perspective. So this again, conceptualizing the diagram where it is. So compassion fatigue, it's highly researched. It's not a phenomenon that is not researched. It is researched, but it's researched in specific areas of oncology, palliative care, dementia care, ICU care, but not the district nursing or the community nursing staff in the UK. The NHS, the Department of Health, the Queen's Nursing Institute, the NMC, the Royal College of Nursing, even the Care Quality Commission, and identify compassion fatigue is an area of concern and that needs to be looked at and explored further. So, literature search that I've done so far, there's some associated terms that come across compassion fatigue. It's used interchangeably with burnout. It is also being classed as a form of PTSD, vicarious trauma, and secondary stress disorder, as well as a term death anxiety, especially when you're looking after end-of-life care and palliative patients. The contributing factors are there's a lot of external factors that are going on. So currently there's a lack of resources, as we know or might not know, within the NHS. There's increasing workload. Continuous exposure is the big thing when it comes to compassion fatigue, is being continually exposed to patient's trauma. And also there's poor organisational support as well as job demands. This leads to, when a person is suffering from compassion fatigue, it leads to increasing sickness levels, staff attrition. I myself left the profession for it, poor patient outcomes, reduce organisational productivity. So the NHS really needs to understand the impact of compassion fatigue because it's impacting their organisation's productivity. So what I wanted to do was to try and find a clear definition of what compassion fatigue is and include research within community nursing staff. And what I really wanted to understand was to understand their lived experience of this fatigue, how they are living through it on a day-to-day basis. So my methodology I've adopted was an ontology is postmodernism. Reality is not singular, it's objective, and it's constructed by the individual and is dependent on their perception and their context. And I wanted to see how they use their language to interpret it and make meaning of it. I've used an interpretive epistemology. My methodology was IPA. Because I wanted to capture the idiographic nature of how how these individuals were going to interpret their experience of compassion fatigue and how this fatigue is manifest, or this phenomena is manifesting in this group of specialist nurses. So I use semi-structured interview to allow a more flexible approach or more of a conversational approach, allowing them to be able to guide the interviews. So my ethical approval was via the university ethics process here. The access to the field, I chose the specialist practitioner SPQ program that we run here at the university. So they are nurses who are working in clinical settings at band 6 level who have come to do the specialist qualification. I'm not sure if people are aware, but to be called a district nurse in the UK, you need to have a specialist practitioner qualification to give you that title. And it's usually a postgrad qualification that is taught over 12 months. So those were the nurses I grabbed, I wanted to capture. And I was very optimistic. I thought I'd grab all the learners in the first group, the first cohort. However, the pickup rate was difficult, and I had to do it over 2 years, over 2 cohorts. So finally, I've had about 88 interviewees who've came forward over 2 years. So my data is qualitative in nature. Semi-structured interviews I carried out via Zoom platform. I transcribed the interviews. I cleaned the transcript, shared it with participants to make sure that they were clear and the clarifications were there. And I completed it using IPA, maintain the principle of the hermeneutic circle of interpreting their data, allowing the participant to make sense and interpret their lived experience, as well as myself as a insider researcher, adding a second layer of interpretation. So that's what, and IPA, I'm not sure people are familiar with IPA. I've followed Smith and Neser's structured way of following IPA, and as well as I'm an insider researcher, I understand the language of what district nursing and the lingo and the acronyms that we use. So that was one of the reasons why I wanted to be an insider researcher. However, because I know I think I've suffered from compassion fatigue myself, it was important to be reflexive and have a reflective diary in making sure I wasn't imposing my understanding or my feelings onto what they were trying to make sense of. I wanted their voice to be always heard through. So I always kept a reflective diary and used my supervisor as a way to bounce and ideas and have a debrief with them while I was capturing the data and analysing it. So the Smith and Neser approach for IPA is reading and rereading the transcript, you're making notes, listening to it, you're making the notes on the language, the description, conceptual notes, after which you start formulating statements and then you cluster these statements and you identify themes for that one transcript. And you have to do it for each transcript at a time. And I've done reflections after each transcript, giving each one the same amount of time before you group them together to bring out overarching themes. So some of my overarching themes were signs of compassion fatigue. There are physical signs of compassion fatigue, as well as emotional and psychological signs of compassion fatigue, which will give you behavioral symptoms from our colleagues or even from yourself. And there are also work-related signs of compassion fatigue. And there are signs that may be seen in yourself, maybe not the same as you've seen in your peers or your colleagues that you're working alongside. And they're also use interchangeable words like burnout and all of that, so linked phrases. Another important thing I found was meaning making at what happens at death and dying. So people resorted to faith as a source of stability and sense making, and others were using rational thoughts and finding support from traditional practices like attending funerals or ritualistic practices that were taking place, that they're finding a sense of meaning making and support in taking part in whatever those ritualistic practice was. Well, they might, like some Buddhist faiths have opening of windows to letting out the soul. And I found that some nurses were actually taking part. They might not have those beliefs, but they were giving them a sense of like happy feeling or warm feeling when they were taking part in those ritualistic practices. And process of mortality through belief of death, of afterlife, and how that supports and how that meaning making supports the individual nurse provide the care that they are providing. And coping and supportive strategies were physical activity, just engaging and going to the gym, walking, reflection, personal faith, mindfulness, nurses becoming creative, social and professional networks, in setting individual protection boundaries or self-soothing mechanisms as well. So one very pertinent phrase came out was, I am burnt out. One of my participants actually said to me, I am burnt out. I am compassion fatigued. So they physically said they could understand they had got there. And they recognized that some of these people recognized that symptoms that they were seeing in themselves, like a patient been given a pseudonym, Jack, was saying he was tired. He would go home and just sleep, had no other reason, even go to the gym or socialize with anybody. All he wanted to do was go home and go sleep. However, others were hyperactive and would sleep, deprived from sleep. So there's like convergence and divergence going on with the symptoms that is very individualized. So what I've recognized that compassion fatigue, signs and symptoms are multifaceted, multidimensional, very individual, and how they present in one person is not how it may present in another person. So that why it makes compassion fatigue so difficult to identify as this is what they are suffering from, compassion fatigue. and we're missing the boat of timely interventions. Meaning making. People make meaning of death and dying. This is very important to them, how they make meaning of it. And even if somebody identifies as, a lot of my participants did identify saying that they did not have faith. Some identified with faith, others said they did not have faith. However, they made meaning of what happens at death and of the soul traveling on to heaven, afterlife, a better place, meeting with their loved ones who've passed away previously. That has supported them and give them comfort when death had occurred to allow them to nurse that next patient as well. Others had very traditional belief, faith in religious belief, like Christians who have interviewed, a belief in an afterlife, in that they was their time to go. So death and making sense of it does not have to be religious based. However, some of the ideas do come from religion, and it just supports the individual, makes sense. So having a personal belief, which does not need to be in any of the traditional religions, it's how they perceive their belief. It's supporting them in making sense of what is happening to the individual at death, and it supports them in making sense of what they are providing care at what stage, and allowing them to make sense and be able to care for the next end of life care patients on the next one. That sometimes in the district nursing caseload, my colleagues are telling me they're not seeing one end of life care patient, they can see up to 4 in a day. So it is a burden on them, and that's how they're making sense to move on and continue providing care. Coping mechanisms, personal peer-to-peer support, an informal debrief, what I'm seeing, because I think district nursing, we are lacking in formalizing debrief sessions. So they're taking part in a lot of informal debrief, like picking up the phone and speaking to the peers about it, talking about it at the start or end of a handover or huddle, as we call it. And this supportive strategy has to be also very personalized. Some people become very creative. Some people are just going for walks or taking up physical activity, or even faith-based approach. Some have told me that they pray at night, carry out reflective journaling, going to church, going to mosque, or just taking part in prayer. That is helping them. So also coping strategies are very personalized, but faith-based approaches are also helping individuals identify their fatigue and be able to manage their fatigue when their services around them are not supporting them. So compassion fatigue is a significant concern among community nursing staff providing end-of-life care. The emotional burden of caring for a dying patient can be intensifying, stressful, and can contribute to compassion fatigue if not adequately addressed. Current working condition is exacerbating the issue. The factor is collectively reducing the nursing capacity to provide with the emotional and physical demands of the job. Formal and informal support systems are essential in helping staff manage compassion fatigue. Structured debrief are very important. These need to be implemented in areas like the community. Wellness, informal support like peer-to-peer discussion are very supportive. Engagement in health and well-being activities such as yoga, mindfulness are also supporting individuals. Overall, a combination of organizational support and individual coping strategies is crucial to help the support nurses recognize, manage, and mitigate their compassion fatigue effectively. So at the moment, at Up at the Writing Up stage, I am presenting at the international conference in a couple of weeks in London. My research is still presenting, and I am writing it up at the moment, writing it up. Hopefully it's done by the end of this year. Even if it's in a rough draft, that is my aim, that I've wrote it up. That's it. Any questions?
Thank you, Rizwana. Such an interesting topic. Like I haven't thought about the compassion fatigue, to be honest. And hearing from your starting with the research gap, aims and objectives, the methodology that you have used, and the participants that you have taken the data from. All interesting. Do you have any questions from the audiences? If you have, maybe raise your hand, or else we will go into the chat section where we have a couple of questions.